Good morning everyone and dear colleagues. Myself is Dr. Visharat Trivedi. I am working as an associate professor in cardiovascular anesthesia department in UNMICRC Institute of Research and Cardiology Center. I have been working here since last 11-12 years, and one of the very important topic which I am going to discuss here today is VENO VENOUS ECMO. As you have previously acquainted with all the histories and all the parts of the ECMO in the previous lecture by Dr. Jigisha madam. Today I am going to focus more and more over VENO VENOUS ECMO, that is VV ECMO in short. So as you all know, acquainted with parts of the ECMO and types of the ECMO, that is mainly two types of ECMO are there, veno arterial ECMO and veno venous ECMO. Veno arterial ECMO, in which you are taking blood in the venous system and getting back giving back the blood in from the arterial side, and in veno venous ECMO you are taking the blood from the venous side and returning the blood back into the venous side as well. So in veno venous ECMO, major difference is there is no arterial support or no hemodynamic support. So veno venous ECMO can be referred to as a respiratory ECMO as well. So it provides only and only support to the gaseous exchange, that is to the lungs only and not to the heart. So this is purely a respiratory ECMO, you can say. So if we look at the history and about the veno venous ECMO, you have previously told also that the first case of veno venous ECMO was happened to be in 1972, but still after 50-55 years of it, the mortality due to respiratory complications are very high. Mainly the main cause of mortality of respiratory ECMO is ARDS, that is acute respiratory distress syndrome, in which ECMO can be proven as a effective modality of treatment. So first successful case was done by Dr. Hill in 1972, who didn't use the oxygenator, but he used the Bremson's membrane as a permeable membrane for gaseous exchange, and they have found it a useful method to gaseous exchange apart from the lungs. So but after that single case, there is no substantial evidence that give adequate evidence to use the ECMO as a single modality of treatment in ARDS or any respiratory complications. So after that, various trials have been performed. In 1986 there is a Gatti-Toni trial, which is a single center observational study, which also shows that there is a survival rate of 48.8% in ECMO candidate who couldn't expire the amount of CO2 which is necessary to maintain the pH. So they used ECCO2R, that is extracorporeal carbon dioxide removal type of circuit, just to remove the carbon dioxide from the lungs. They have found some success rate in 48.8%. Another single center RCT has performed from 1987 to 1991 by Morris et al., which doesn't show any change in survival rate also. So after first case in 1972, 50-55 years, we haven't had got a single very good large number of studies with a large number of patients who confirm that an ECMO as a modality of treatment in ARDS. But the major breakthrough trial comes in 2009, which is published as a Cesar trial. The trial runs from 2001 to 2004. And it published in 2009, which shows that the mortality rate is statistically significantly lower in ECMO group, in about 63%. Survival rate is 63%, while in conventional group it is 47%. So what they have done is, previously what trials we have seen till now, Hill trial, Gatti-Toni trial and all the trials have used the ECMO, but they haven't used the lung protective strategies on the ventilators. So they used to ventilate the lungs with a very high pressures and very high plateau pressures, very high respiratory rate, and all that stuff will also cause the injury to the lungs. So because of these high pressures, there are continuously injury to the alveolar shearing forces and continuous injury to the lungs, so that the lungs will not recover even after the ECMO. So what this after the ARDSNet trial for ARDS per se, and they have performed the lung protective strategies in various trials, and they have shown that the low pressures, low plateau pressures and high rate and a high PEEP will cause a lung protection in on ventilator. So what CESAR trial has done is they have put the patients on ECMO versus the conventional, but on ECMO also they use the lung protective strategies. They maintain the peak inspiratory pressure of around 20-25, PEEP with a PEEP of 10 to 15 centimeter of H2O, and frequency respiratory rate is around 10 per minute, so that the lung should be protected, and so they got the good results, and that it proves to be a breakthrough trial in case of a VV ECMO or respiratory ECMO. After that, various studies have shown a benefit of ECMO in ARDS patients, particularly in viral influenza or viral pneumonitis cases, in which one study published in Australia and New Zealand ECMO Society in 2009, they also showed that the survival rate of around 76%, and currently according to the ELSO registry, the survival rate is around 60 to 70%. So after knowing this history, we come to know that the management chart of the ARDS, or you can say any respiratory complication patient who is not maintaining gaseous exchange, you can use ECMO as a modality of gaseous exchange. So you can say that ECMO is actually a non-conventional method of ventilation only. So, but you have to follow the proper hierarchy or proper flow chart for management of that thing. First, you should put the patient on lung protective strategies like low tidal volume, high rate, high PEEP. Then even after higher PEEP, you don't get a good gaseous section, then you have to go for a prone position. If after that also there you are not getting any saturation, then go for a high frequency ventilation, and after that you have to go for ECMO. So ECMO is definitely nowadays is a method of choice in case of a severe ARDS where PaO to FiO2 ratio is less than 100%, less than 100. So coming back to the indications of VV ECMO, in which patients you would like to put a VV ECMO, that is more important. So first and foremost, as we have discussed, that it doesn't provide any hemodynamic support, so it is purely a respiratory support. It does not have any circulatory support. So any condition, any complication which will lead to respiratory impairment in terms of mortality, risk of mortality is if it is more than 50%, or risk of mortality is more than 80%. Now how can you judge that the risk of mortality is more than 50%? Then you can judge by a Murray score, that is PaO to FiO2 ratio if it is less than 150, on FiO2 more than 90%, and Murray score is more than 2 or 3, or PaO to FiO2 ratio less than 100 on FiO2 90%, and Murray score more than 3. So all of the patients are subjected to ECMO. Airway oxygenation index, if it is more than 80, then also it can be an indication for ECMO. CO2 retention again is an indication of ECMO. If the patient is not able to expired amount of CO2 which is necessary to maintain the pH, then you can have an ECMO use for it also. That is known as ECCO2R. Okay. Severe air leak syndrome, severe large bronchopulmonary fistulas, immediate cardiac or respiratory collapse in case of pulmonary embolism or blocked airway, you can use respiratory ECMO in that patients. Murray score, as we have discussed previously, these 4 criteria should be used to calculate the Murray score, that is PaO to FiO2 ratio, chest X-ray, PEEP, and compliance of the lung. This is another score which is age, plateau pressure, and PaO to FiO2 ratio. If the score is completely total 9-point outcome, if the score is on the higher side, then patient is required higher supports, that is in the form of ECMO. If the score is on the lower side, then you can use lung protective strategy as a method of treatment. Now what are the contraindications for ECMO? But this is particularly for VENO venous ECMO. So absolutely there is no contraindication, but however, if the patient is there on mechanical ventilation for more than 7 days, that means the respiratory condition for which patient is on ventilation is likely to be irreversible, then you should not put an ECMO. Major pharmacological immunosuppression if going on is like the patient is of transplant, then the ECMO can be challenging. If there is any chances of bleeding, recent hemorrhages, CNS hemorrhages or expanding hemorrhages there, then you should not put an ECMO. A non-recoverable malignant comorbidity could be relative contraindications. And in some countries, if there is a very, very high BMI or high elderly patients, then you should not put an ECMO. So these are the parts of the ECMO machine which you have, I think you must be acquainted in the previous lecture. The mainly 4 parts are there for VV ECMO. First is a pump, second is a console, third is a membrane oxygenator, and the fourth is a blender. So cannulation strategy for VV ECMO, as you all know that we are cannulating both the veins basically. We are taking the blood from the major veins and we are giving blood back to the major veins as well. So mainly used is femoral veins, bilateral femoral veins, and one jugular veins. So out of these 3 veins you can use whatever vein you want, preferably femoral cannula, femoro-arterial cannula can be used, and one another cannula which is known as Avalon cannula, which is a single cannula with 2 lumens, can be used in some patients for ease of insertion. So you can see in this figure that the first figure is dual cannula. Both cannulas are in a major vein. So in first A figure, you can see that we are taking blood from the jugular and we are giving it back into the femoral. Second B figure, we are taking the blood from the femoral cannulas and we are giving it back into the IJV. Preferably the second B figure would be more preferable choice of as the anatomical landmarks, because the femoral cannula are more we are taking blood from the RA and we are giving it back into the RA through SVC. So SVC is more inclined towards the tricuspid valve. So the blood which you are giving, oxygenated blood, is more going into the systemic circulation rather than coming back into the femoral vein via recirculation. The second figure which you can see is a single cannula 2 lumen catheter, in which there is a 2 lumen in a single cannula. So 1 lumen is directed towards the IVC. So from there it is taking blood from the IVC, and another lumen is opening right in the midway just above the tricuspid valve. So we are giving blood back into that lumen. So the blood which is getting oxygenated into the ECMO is giving back into the second lumen just above the tricuspid valve and going into the systems. That is known as Avalon cannula. Now we just look at the principles of VV ECMO, how it will work. So once you put the ECMO, the initial period the lungs do not contribute to any kind of gaseous exchange because of the lung pathology. So patient has a severe respiratory complications and patient doesn't maintain any gaseous exchange through the native lung, so that just right after the initiation of the VV ECMO, the whole gaseous exchange occurring at the oxygenator level. So here comes the important concept of hypoxia versus hypoxemia. So you are taking blood from the venous system, you are oxygenating it into the oxygenator and giving back again into the venous system, and so whole of the blood which is getting back into the venous system is getting mixed with the normal deoxygenated blood coming into the venous system. So the total saturation of that blood is around 80-85% saturation. So that blood is going into the system through RV to pulmonary without taking part in the gaseous exchange from the native lung and to the systems. So systemic circulation can be as low as 80-85% in VV ECMO, but that you have to accept it, and you have to accept that hypoxia of 80-85%, but you have to simultaneously maintain the hemoglobin level and so the oxygen carrying capacity of the blood to maintain the oxygen delivery to the tissues. So you try to maintain 80-85% of saturation with optimal flow and optimal systems settings, and then try to adjust the hemoglobin level according to that to maintain the oxygen carrying capacity of the blood. Gaseous exchange is performed at the membrane oxygenator right at the time of initiation, and any venous blood that is not entering into the ECMO circuit is directly shunted back to the lung. So the blood which is not getting into the systems and not getting sucked into the ECMO is directly going without oxygenation into the system, so it gets mixed with the oxygenated blood which is coming through the ECMO, and so our final oxygenation would be on the lower side. So this is the pictorial presentation, very easy to understand, that the oxygen, the blood which is not going into the ECMO circuit is getting directly into the systems, and so the saturation of the total blood is getting mixed with oxygenated blood with deoxygenated blood. So in acute phase, blood is oxygenated via ECMO, and the only way to increase the saturation is to increase the ECMO flow or decrease the shunt flow and increase the circuit FiO2. Now this is very important. If you have started the VV ECMO and you see that the saturation is still not picking up, saturation is around 65 to 70%. So how you can increase the saturation? Very easy. You just have to increase the FiO2 on the ECMO so that the oxygenation occurring at the oxygenator is maximum. Then you have to increase the ECMO flow so that the majority of your blood will go into the ECMO circuit and then getting oxygenated and then getting back into the system, so that you are likely to reduce this shunt flow which is not getting into the ECMO and directly into the system. So what you can do is increases the ECMO flow, increases the FiO2, or basically your purpose is to decrease the shunt flow. Now how is the oxygen delivered into the tissue is, the oxygen delivery is actually flow into hemoglobin into saturation into 1.34 plus PO2 into 0.003. Now in VV ECMO, this equation is little bit changed because oxygen is not getting exchange at the lung level. So in VV ECMO, oxygen supplied is extracorporeal flow, that is ECMO flow, into 1.39 ml of O2 plus per gram of hemoglobin into hemoglobin into 10 into out saturation minus in saturation. That means saturation of the returning cannula minus saturation of the indwelling cannula. So in pulmonary, if pulmonary oxygenation improves, the amount of O2 supplied by the ECMO should be decreased. How? You can see that. So this is a chart which shows that after a certain days, after 20-25 days, the lung starts to recover. So once the lung starts to recover, the lung will also take part into the gaseous exchange, so that the oxygenated blood which is presenting at the pulmonary level is also getting more oxygenated from the lungs. So the returning blood which is there returning blood to the ECMO cannula having a more saturation. So the gradient of oxygenation between the oxygenator is decreased. So the oxygen exchange at the oxygenator is decreased, and so the oxygen provided by the ECMO circuit is decreased. So the contribution of the ECMO in oxygenation is decreased. I hope you are getting my point. So basically how you can see that is, as the lung has started to improve, the lung is also taking part into the oxygenation. So the ECMO will try to reduce the improvement in the oxygen at the oxygenator level. So in this graph you can see that the VO2 of ECMO, this is purely of ECMO, is after 30 days, once the lung starts improving, the VO2 of ECMO reduces quite significantly, and so as the lung improves, your VO2 will reduces. So during oxygen should be delivered during the ECMO from the lungs is depending on cardiac output, alveolar recruitment, lung compliance, ventilator FiO2 and mean airway pressure PEEP, which is totally zero right at the start of the lung VV ECMO. Gradually it will take part in the oxygenation. And from the membrane oxygenator, it depends on mainly blood flow, sweep gas flow, sweep FiO2 and oxygenator efficiency. For CO2, this is again very important. Sweep gas flow is actually a directly relation with the CO2 level in the blood. So as you increases gradually the sweep gas flow, your CO2 will fall down. So this is again a chartical presentation of that part only. So initially you need to increase the sweep gas flow just to maintain the CO2 around 45-50 level. You have to start the sweep gas flow at 1:1 with ECMO flow, and if required you can go up to 1:15 as well. Thanks a lot.